to the right of it.
We're gonna sing a Bollywood song. There we go.
Good afternoon, everyone. I want to welcome you to our Reentry Network meeting for February 8th, 2023. I'm now calling the meeting to order, and I'm going to begin with public comment. Oh, actually, I'm sorry. I'm going to ask if we could do a roll call vote to get us started. Am I correct, Cynthia?
We're going to start with roll call,
Yeah.
just to confirm a quorum. Yeah. Chairperson Chavez?
Here.
Member Johnson? Here. Alternate Member Binder? Member Tomalinas? Member Zahner? Absent. Member Smith? Alternate Member Glee? Here. Member Bouchard?
Here.
Member Cody? Absent. Alternate Member McClinton Brown is absent. Member Esparza? Member O'Neill?
Good afternoon, I'm present.
Thank you. Alternate Member Silver? Member Rosen? Alternate Member Angel? Member Nikolai? Here. Member Portia Usher? Alternate Member Shing? Member Terrell? Member Mills?
Here.
Member Dewan? Member Bondures? Member
Present.
Oh, thank you. Member Joalaxa? Member Fisk?
Here.
Alternate Member Reagan? Member Hanson? Alternate Member Halcon? Present. Thank you. Member O'Brien? Member Amador Lebreu? Alternate Member Trinidad? Here. Thank you. Member Williams? Alternate Member Yee? Member Clifford? Here. Member Manley? Here. Member Hernandez? Member Day?
Here.
Thank you. Alternate Member Permanta? Member Loftus? Alternate Member Wolfberg? Member Vugini? Alternate Member Brahim? Here. Thank you. Member Mata? Alternate Member Joseph? Member Wiggins? Member Kyung? Member Kendrick? And Member Ellenberg? I'm here. Thank you. You have a quorum.
Thank you, and I apologize, Cynthia, you're going to have to do that again in just a moment. So with that, we're going to go to public comment, and this is an opportunity to speak to an item that is not on the agenda, but within the purview of the committee. Do we have any public comment?
We do have public comment, and it looks like we have one for item 2, public comment. Would you like to set the timer at 2 or 3 minutes?
3 is fine, thank you.
Paul Soto, you will have 3 minutes to speak. Please make your way up to the podium.
Good afternoon, Judge Manley, members of the Reentry Network. My name is Paul Soto, and I'm from the Horseshoe. I'd like to preface what I'm going to say from a letter from a Birmingham jail written by Martin Luther King, 1963, while he was locked up in the Birmingham jail in Alabama. And I quote, "Actually, we who engage in the nonviolent direct action are not the creators of tension. We merely bring it to the surface, the hidden tension that is already alive. We bring it out into the open where it can be seen and dealt with, like a boil that can never be cured so long as it is covered up, but must be open with all of its ugliness to the natural medicines of light and air. Injustice must be exposed with all the tension in its exposure, its exposure creates to the light of human consciousness and the air of national opinion before it can be cured," end quote. And I'm saddened by yesterday, there was a policy that was put in place with respect to the jails and the lives of Andrew Hogan and Juan Nunez. And the policy was, and it scared me, the policy is that a guard is now tasked with administering first aid when necessary. That is a new policy now. So it raises questions. Number one, why was that not a policy to begin with? Number two, as human beings, do we really need a policy in order to administer first aid to a suffering human being, irregardless of his status? These are legitimate questions that need to be asked within the context of this meeting. When it comes to the light of air and air and light is truth and honesty. Those are the two. Those are the remedies. And what the county has done is paid out $7 million in a no-fault agreement with the families, which means I'm deprived of a jury trial where that light and air, truth and honesty can be administered, brought to the surface so that justice can be done. These are the things that we contend with. I've suffered for 35 years of my life inside those jails, inside those prisons. And you are tasked in order to do what it is that we can together, not us and you, not me and you, but us. And what we can do in order to really deal in a very humane, very compassionate way with the suffering that has gone on in those jails, because I've seen it and I still live with it every single day. I do. And so I'm tasked with the responsibility of coming here and creating that tension. Thank you.
And that concludes public comment.
Thank you very much. I'll now move to our consent calendar. And colleagues, what I'd like to do is put the December 14th meeting minutes, the revised meeting schedule for 2023, the 2023 work plan, and the reentry resource quarterly dashboard on consent. And then I'd like to hear item 8 and then item 5 and hear them together because they're pretty aligned. What that would mean is that our agenda would go 4, 6, 7, and then 8, and 5 is one item. May I get a motion for the consent calendar and a change to the agenda?
I'm happy to move approval and would like to make a brief comment on item 11. That's all
Absolutely.
right.
So we have a motion and a second from Judge Manley.
And we do have public comment. Would you like to take that now or afterwards?
I'll have Supervisor Ellenberg or anybody else who wants to make a comment on the consent calendar, and then we'll go to public comment. Thank you.
Thank you so much. Regarding item 11, the work plan, at the previous meeting, I'd voiced concern that the 2-year reentry strategic plan that we had received wasn't incorporated into the committee's work plan, and asked that this be done. And I believe you did express agreement to that, but I didn't see the work plan attached to this agenda. So I'd like to just reconfirm that can be added to the agenda, revisiting to the work plan, so that we're revisiting the reentry strategic goals and our progress on them, either quarterly or biannually.
I think that's a great idea, and we'll make sure we take care of that.
Thank you.
Thank you. We'll now go to public comment. This will be 2 minutes each. Thank you.
Okay, perfect. Paul Soto, you'll have 2 minutes. Please come to the podium.
Paul Soto from the Horseshoe. On the minute or on the consent calendar, I was hoping to discuss the wait times of people in jail. So when you get put on the cap list, you're sitting in jail, but you've committed no crime. This is a serious issue. And the reason why it's a serious issue is Michael Tyree did not commit a crime. He was waiting in jail for a bed. Why? Because of the deficiencies that were created because we used the jails and the prison systems as mental health institutions. We were locking people up and thank God for Judge Manley, because we were locking people up for drugs, for untreated addictions and untreated mental health issues. We were going 32 per bus every Monday, Wednesday, and Friday for 15 years to San Quentin. I was on those buses. And so what happened to Michael Tyree would have been amended and would have never happened had there been a placement for him in the community, because he was placed there because there was no other place else to go. And it was the judgment of the court in order for Michael's protection to stay there because there was no other suitable place for him. And that was probably the most dangerous place that he could have been, because he was savagely murdered in that cell. And those men, those guards are coming back. They beat their trial. They're coming back to this county, and this is going to be ripped right open again. Why? Because of that lance. We didn't lance the boil. We didn't get honest about what had happened. And so it is critically important that we openly discuss the deficiencies that were created when we had the three-strike shootout law instituted, because we were just being sent to prison and we were suffering in prison, and when we experienced symptoms in there and we came out and the symptoms started manifesting, we were arrested for it. And Judge Manley was the only barrier between those two. Thank you.
And that concludes public comment.
Thank you, Cynthia. So we're going to move on to item.
Well, let me go
I'm
ahead and
sorry.
take the
You want to
vote.
take a vote?
Thank
Okay.
you.
Thank
All right,
you.
here
So
we
we have
go.
a motion and a second.
Yep.
Thank you.
Chairperson Chavez?
Yes.
Member Johnson? Yes. Member Tomalinas? Member Klee? Member Bouchard?
Yes.
Member O'Neill? Yes. Member Nicolai? Yes. Member Mills?
Yes.
Thank you. Member Bonduras?
Yes.
Member Fisk?
Yes.
Member Halcon? Yes. Member Trinidad? Yes. Member Clifford? Yes. Member Manley? Yes. Member Day?
Yes.
Member Brahim? Yes. Member Ellenberg? Yes. Thank you. The motion carries.
Thank you. And did anybody arrive that wasn't included in the roll? No, okay.
Yes, they did actually. The Director of Victim Services, Tasha Wiggins, and she's in the audience.
Oh, Tasha, you should actually be up here. Welcome. So Tasha's new, and we didn't tell her she was on this committee, so I'm glad you're here. We'll make sure we swear you in. They'll swear you in, and then we'll seat you. Thank you, Casey, for catching that. Take a picture for her. So Tasha will be joining us up here, and thanks again, Casey. So what I'd like to do is I'd like to move to item 4, and this is a report from Custody Health Services relating to the discharge planning process upon booking into jail and the collection of the individual's medical and behavioral health information. And Dr. Day, I understand you're going to be leading this presentation?
Yes.
Great, thank you.
And my team is setting up. Okay, good afternoon Supervisor Chavez and Supervisor Ellenberg. Eureka Day here to report on our follow-up discussion on our new discharge clerk program, and also to address some questions posed by Judge Manley on our discharge starting at the point of admission. Next slide. And as a recap, Custody Health Services does have a section under the Federal Consent Decree that addresses discharges. That's under Section H, number 55. And the requirement is that we provide integrated mental health, and dental information upon release from the jails if we're being notified within 72 hours of release. Our program currently right now is exceeding that, since we are also wrapping around any unplanned and/or impromptu discharge. Next slide. And so discharge planning does happen at the beginning of a patient coming into booking upon admission. We have a two-tier process. We have a process in the first tier where we are doing a comprehensive nursing assessment. The first tier, we're first accepting the patient into booking if they are medically stable and/or stable mental health-wise. If they are not medically stable and/or stable under mental health conditions, we do send them out to the hospitals and/or to the emergency room. Once we accept the patient into booking, we do a second tier, which is a comprehensive nursing assessment, and we look at all areas of the health care. We look at their medical condition, mental health conditions, oral health, we do vitals. We also look at disabilities, if they need any kind of durable medical equipment and/or what we call DME. We look at suicide and suicidality and any triggers for mental health consultation. If there is a consultation that needs to be done by our mental health clinicians, they need to see that patient within 4 hours of that consult. We also look at women's health. Any woman coming into our booking who is of childbearing age, we also do a pregnancy test upon admission. Next slide. And so we do look at where the patient comes from. If they have been in our custody services before and they have what we call a PFN number, we pull that information, and if they have a PFN number, we continue with that same number. And so we're pulling all information that the patient may have had prior to coming back into jail, and so we use that information to inform care. We also look at if they have been treated in the health and hospital systems in the county under the Health Link and Care Everywhere. And if they have, we pull that information as well. We look at any previous care that they may have had. We also link any outstanding appointments that they may have, labs that they may have, and any other prescribed medications, and we do medication reconciliation. And so that begins that process of discharge happening at the point of admission, as well as informing the course in care when the patients come in. If they don't have any previous care in the county and/or any previous incarceration with the jails, then we begin a new process and assign a medical record and then register them in and start at a baseline with the entire process of medical, mental health, and dental, doing an assessment on that patient once they're housed. Next slide. And so at discharge, basically the discharge happening at the point of admission, and also looking at the patients if they have previous histories with us, any updated information that they have already in the Health Link, and/or if they don't have any information at all, we do begin that process at the point of admission, either having to assign based on acuity them to be seen by our medical, mental health, and dental upon admission. And so lastly, we also go into the record if they have a current record, again, to see if they have any outstanding assessments, labs, appointments with specialty, and so that we build that into their processes in the jails, and we do that continuity of care and follow-up. Next slide. And so we talked about before that we have 3 different kind of discharges and releases. We have those planned releases that are treatment-oriented. We have planned releases where the patient may be going either to CDCR, DSH, and/or other treatment places. And then we have those unplanned impromptu discharges. And so the planned discharges to treatment as well as to other places like the prisons, for instance, are very structured. They're very planful. We can plan for that continuity and care. And we also do what we call an SBAR. And the SBAR is a nursing communication and handoff where it's based on situation, background, assessment, and recommendations. So they do a handoff to that receiving institution and/or that receiving program. Information that will go is any information around medications that the patient may be on, any labs, any treatment that they've had, medical appointments that they may have had, and so that we do that smooth handoff for continuity and care. Those patients that are coming up on release where it's an impromptu, planned, we also are doing what we call that sort of AVS, which is an after visit summary. On that after visit summary will be the patient's diagnosis, information on the care that they've had, any information that they have about follow-up appointments, labs that they may have not gotten before the release. And we also are providing them a step-by-step process on how to access the My Health, where they can go and register and pull that information up. And so part of the planned releases, too, is that we work with our reentry network. We work with the medical mobile unit. We've worked with Roots and other handoffs for medical and mental health care. We also work with the behavioral health colleagues where we shepherd the patient through that discharge. They come into our facilities. They will shepherd through as far as medications, taking the patient to get their medications, as well as any referrals that we've made internally that they will program with once into the community. Next slide. And so part of the medical unit clerk and the discharge program that we put together is to really wrap around those unplanned discharges that happen impromptly that we're not able to adequately plan around. We have medical unit clerks that are co-located with our release officers and work with nursing, and so that in tandem, as patients are being processed through the custody side of the house, we're also looking at their information that we need to provide upon release. The volume at Elmwood is much higher than it is at Main Jail. So the 6 clerks that we have on board right now, well, we have 4 on board and we're onboarding 2, are primarily working on every shift to co-locate and release, get the information to the patients as they're being released in tandem with other release officers. On the weekends, however, we are looking to cover that. We don't currently have the weekends covered, but what we're doing is looking into the CJIC on those Thursday and Friday prior to the weekend, and any patients that are being released or coming up on release, we put a package together so that that's put in their property so they get all the same information, AVS, after visit summary, as well as information on reentry, on My Health, on how to register for My Health, as well as information on housing, shelter, and any other information that we can provide them upon release. Next slide. So this is just our systems flow, and this covers all types of releases, the program release as well as the planned release and those unplanned releases. And each part of the system, our medical unit clerks sort of, meet with the patients individually and provide the necessary information for them to have. In addition to that, those planned discharges that are going to either the prison, CDCR, and/or DISH are having that SBAR handoff by nursing as well. Next slide. And so to the point where some of the patients come into the courts prior to or not having any kind of discharge plan, oftentimes they go into the court for arraignment prior to their scheduled appointments. We do schedule appointments for the patients based on acuity levels, so there's acuity level for urgent, emergent, and routine, and sometimes if there's a routine appointment that may be scheduled after they're going to arraignment, so there's sometimes a disconnect. Judge Manley will often reach out to us for information that we try to provide and be responsive to get into so that he knows what's going on with the patients. But the discharges that we do work with that are not planned and/or the patients that are going to the courts, we try to get that information timely to make sure that prior to going into the courts, we fill out the information that our behavioral health colleagues, as well as Judge Manley, can have in his hands about the treatment of the patient and while they're incarcerated. Okay, and so we will be doing another follow-up in June as we continue to evolve this program. And so if there's any other questions that you may have now and/or that you'd like us to address in June, we're open for that.
Thank you, Dr. Day. Do we have any public comment on this item?
Yes, we do have one speaker.
We'll take public comment, and then I'll come to colleagues for comments or questions.
Perfect. Paul Soto, if you'd like to come to the podium, you'll have 2 minutes to speak.
Paul Soto from the Horseshoe. Unplanned releases, I think the name needs to be changed. We discussed this, and Judge Manley spoke on it at length at the last meeting, is that you are going to leave. Right when you come in, you're going to leave the jail. So people that cycle in the jail, it's a core group of people, so they've already been medically assessed. So at the time of booking, their medical records can be immediately accessed because they had received medications at a prior visit to the county jail. So this is already documented. That's number one. Number two, Judge Manley cannot make an assessment if the person has not been stabilized on medications. Until that point, Judge Manley is mandated to know this is mental health court. You're not leaving until you stabilize. And a lot of the times, that's not his fault, or it's not the client's fault or the patient at that point. It's the medical system has not, for whatever reasons, has not assessed the person and given the medications. And even if they received it that day, you have like maybe about 5 or 7 days because the person has a certain degree of coherency and is stabilized on the medications, and then is amenable to whatever services he receives upon release. And so Judge Manley is kind of put in this position where he has sometimes this compelling medical staff. Like, hey, when's this guy's appointment? He's got to get an appointment quick because we can't do this. So there's that piece. The other piece is inside this document, it says that there's a face-to-face with the clerk. That does not happen. That does not happen. 35 years of experience in that jail, that does not happen. I'm not saying that as a critique. I'm saying that it's in this document, and that's not a reality. You will not sit in front of a medical clerk before you get released. That just does not happen at all. So those are the issues that I wanted to hopefully discuss to amend. Thank you.
And that concludes public comment.
Thank you. I'm going to look around and start to my right and see if there are any comments or questions. I don't see any on this side, Judge Manley, and then Susan. Let's start
Thank
fighting
you.
that mic.
I wanted to, perhaps my remarks or my questions relate not only to 4, but the 5 and 8 as well. The federal government granted California, I believe, one of 8 or 9 states, a waiver, the 1115 waiver, as to the utilization of Medicaid funds going into the jail, in reach, and a great number of services that are going to be available. And that program can go into effect as soon as April of 2024. So the program, the way it is set up in California and the way it's funded, and I assume most people may not be aware of this, but it does not run through county behavioral health, but through the managed care plans. Now, of course, we have 2 of them, and they can decide to contract with community providers. But it seems to me that this is a point where we could really start planning now to be prepared so that we don't wait an extra year, because I think you have 9 to 12 months to implement before we can implement these new services, which include temporary housing, in reach by behavioral health, working on the issue of individuals that are only in there a short time, stopping people from going into the jail by, for example, there's funding available for sobering stations, which we talk about many times, to triage people into treatment and to try and get them into treatment rather than keeping them in custody. And I think this is really could be a game changer for us if we took advantage of it, and I hope we do. But I would really like to see us start the discussion now rather than wait when we're going to be under a great deal of pressure because there's so much to be done. So I just raised that for those 3 items. Thank you.
Thank you, Judge Manley. Dr. Day, do you want to give some
Sure,
thought
I
on
can
that?
address that, and thank you, Judge Manley. And we are working on that currently. We do have a work group under CalAIM looking at these services under the 115 provisions. We do have a Justice Involved group that all Justice Involved colleagues and stakeholders across the county are meeting to look at this. Part of that is that CBOs and other folks can come into the jails during the period while the patient is still incarcerated and or detained and begin treatment and then follow the patient out. We started our pre-Medi-Cal application process, and we built that into our booking. And so we have a cascade of questions that we're asking upon booking to determine if the patient already has an application on file, if they don't have an application, if they have an application in another county, and then continue to get those applications completed as much as we can prior to release. And so the entry into the jails, this enhanced care coordination, is something we're working on now as Justice Involved stakeholders, and that will actually bridge, and we're building it also into our whole person care discharge planning to bridge the patient back into the community so that when they do leave, they have a trusted relationship built with folks and that there won't be any gaps in their care. And I will mention that the medical unit clerk program is a 6-month-old program, so it was not in place for the past years. So.
Thank you. Susan?
Thank you for the report, Dr. Day. I have a couple of questions, but Judge Manley, I know we've talked about this so often, and when I hear you say game changer, I'm so hopeful, but the game changing, of course, is going to depend on our having those resources ready, including the housing. So whether we're talking about AOT or care court or this new push-in model, I think it is incumbent on the county now, today, to be working on all of these resources so that as soon as the service is available, we have the workforce in place, the services in place, and the housing ready to go. So thank you very much for that. Dr. Day, I just wanted to clarify a couple of things on the slides. Really appreciated the report. Slide 3 notes that the RN does a medical assessment and that the mental health clinician does an assessment if needed. So I'm wondering if the mental health assessment screening is conducted for every person at booking, or does the nurse make a judgment call as to who to screen?
Sure. And so part of the assessment that the nurses do is a mental health assessment as well. And they're also making sure that the patient is not suicidal and/or in acute distress. And if there are, they do a mental health consult where we have clinicians that are in our booking. And we also have a psychiatrist that is in our booking periodically. And they will see the patient within 4 hours and determine the level of care that they would need. And so that's in the booking process.
So I'm restating mostly for
Okay.
myself here. So every patient is screened by the nurse, and the nurse is looking not only at their physical medical health, but is also looking at the mental health. And if they see a concern, then they move that person to the next level of mental health assessment?
That's correct.
And what tool, is the nurse using a particular mental health screening tool? How are they basing their decisions?
We have questions that have been vetted through our consent decree, and they're pretty consistent with the same questions that our mental health colleagues use in the community. And so every patient that we accept in that are part of that Tier 2 process are asked the same questions. And so also, if we have a patient that comes in and they've been in the mental health program before while in the jails, they will automatically go back into the mental health program, regardless if they say that they're not having any issues and/or that they're not acutely distressed, they will automatically go back into the mental health program.
And do we track the accuracy of those decisions? For example, do we know how many people in custody may manifest a mental health challenge that wasn't caught at the beginning? Are we catching them all, and are we tracking our success there?
We are tracking those patients, and it's just not a one-time look, because if they go into the unit, anytime we can have a mental health consult. So anyone could submit a mental health consult on a patient, and so that's any point in their care. It could be at the beginning, it could be in the middle, but any time that the patient is under any kind of stress or duress, we can issue a mental health consult.
Got it. Okay, that's super helpful. Thanks. Finally, the report indicates that as part of the intake screening, the nurse looks up records in HealthLink for their other medical records. Do they also have access to the behavioral health electronic health record to see if there are current mental health or substance use services being provided?
They can pull up the avatars provisional and look through Avatar as well.
Sorry, what does that mean, that they can do
Avatar
it and that
is
it's
the
provisional?
behavioral health record.
Oh, sorry, I know what Avatar is, but when you say they can, does that mean they do it if there's a mental health screening need?
They should. I can't say that they do it all the time, but they do look at the record. They look at Avatar. They look at previous care. They look at previous care in the county as well as in behavioral health.
Okay, great. Thank you so much.
Are there any other comments or questions on this section? I don't see any hands. First of all, thank you for the presentation. And colleagues, that you may recall that one of the reasons that I've been so interested in this is I'm very interested in making sure that folks who are in our custody have access to the medication they need when they leave, and that they have enough of it to not have, to fall between the cracks as they're going to get medication filled. So one just follow-up question I have is on the package when people are leaving, Dr. Day, I'm presuming that if they have medication that they need, that there is somebody making sure, A, they have that medication, and B, that they know how to take it. Is that accurate?
They don't have the medication in hand because it does take, we don't have an on-site pharmacy. What they do have is their medications that they are being prescribed. They get a 30-day script for the medications. Then they get where to go fill those medications in the community.
Got it.
And
So they're still
they-
not leaving with medication?
Not for the
Okay.
unplanned, no.
So this has been a struggle, I think, between me and, not you, but a struggle between me and the healthcare system. And I don't yet really understand. It seems to me that most jails that didn't want to see people back again would make sure that they got their medication before they left. And so my question is, are there jails in our state, do you know of, that do in fact prescribe or have medication available as people leave and don't send them off to try to get a prescription?
We're able to do that for those planned discharges more easily than we can for the unprompt discharges, simply because with the way the medications are being prescribed, they take almost 24 hours sometimes from our pharmacy to get them filled. And so we don't have the capacity to do that in real time when the discharges are unplanned.
So Dr. Day, does that mean that somebody who does have a planned discharge does get medication when they leave?
They also get the script, and for behavioral health, for instance, they will help for those program discharges. They will actually get those medications filled for the patient. So they will basically shepherd the patient, get them to the pharmacies, and get the medications filled, and that's part of their conduit to the care.
And, got it. So, I think what I'm going to do, and I will say this because Supervisor Ellenberg, I think I need to, because you and I are Brown acted with anything we talk about here, but I would be very interested in knowing, now that you've had some time under your belt, Dr. Day, and by the way, I just want to say to you and your team, the improvement has been dramatic. I mean, really, truly dramatic. And the reason I'm pushing on this last element is I believe that it is really a missing piece to us being able to help people properly launch back into the community. I think it's well, anyway, I think you've heard me talk about this. So what I would be interested in getting from you through the county executive's office is a recommendation about how you would recommend we approach the issue of getting people the medication they need on site before they leave for at least some number of days. To me, having a week to get stabilized and get medication may make sense, but there may be some medications that does or doesn't work for. I know it's a more complex issue. And what I would like to do is, I think I'll have to look at the referral list. I feel like this is one I've done a number of times through the county exec's office, but I will be bringing something forward before June. I think this is such a big gap that I think we're missing an opportunity really to address a significant issue relative to recidivism by not doing this. And so I don't know the best way to do it, which is why I've been interested in letting you get a little more time under your belt again to try this again. But I would be interested in getting feedback on that prior to the June budget hearings, because when we get into workshops in May, I'll be asking this question again, but we'll want your feedback, and Sheriff Johnson, yours as well. So that's one issue. The second thing is that I think people, and I would just caution all of you as staff when you're bringing reports to committees like this, I think absent putting the number and the volume that you're dealing with, it's hard to understand how people get missed and how challenging, and we're going to talk a little bit about our discharge policy, but how challenging this is. And so I think that when you have an opportunity to give us an update on how this is all proceeding, that where you look at the planned releases, the treatment program plan releases, and unplanned, I think that unplanned number has got to be a supermajority. And
It is.
and so, so I just think that that's going to be an important story to continue to tell. And I would say for all of you, bringing reports to us that don't have the number of people that are being served it's unhelpful to the public and to us, and frankly, to the good work that you're doing, because the volume is actually incredible.
We'll provide that for you.
Thank you. All right, I think I'm going to ask, do we have counsel here today? Oh, Kavita, I'm so sorry. I really do need to get a new prescription. Oh, there you are, Kavita. And Deborah, Deborah's not in trouble. She could be sitting up here. She just didn't want to sit with us. But Kavita, on these reports where we're receiving them, we don't really need to take action unless we're giving direction. Is that accurate?
That's right. You don't need to take a vote on receive report items. And I'm huddling down here because I don't fit on the dais for this large meeting, but I
we're all
am
like-
here and I can see you.
I was going to say, Key, no one wants to sit next to you. I saw you try to get Deborah there. I'm just teasing you. But, all right, so thank you. I think on this item, what I will just say is that if we could get an off-agenda report to the board that acknowledges the number of people that are under each category, how many are receiving medications when they leave, or what percentage that, and I know this is something that may not be a known, but the percentage of people who need medication or actually I guess you would know, everybody who gets a script when they leave, over the course of a snapshot of a year, because I think that would help the board understand whether or not the investment necessary would be worthwhile. I think that's really where we've had a delta of agreement. And then the other thing is, it relates to the 1115 waiver. I think what Judge Manley asked about was a really important point about where we are in terms of preparation. What I will do is bring an update to the work plan to include that report out here based on the recommendations made by the two of you. All right, good. Thank you all. Thanks very much for that. Okay, we're going to go on now to, let me see, I moved things around, to item 6. And this item, yeah, what we're going to do is we're going to go 4, 6, 7, 8, and 5 together. So 6 is a quarterly progress report on the implementation efforts relating to the placement for high-needs women leaving the county jail. And I'll welcome you, Javier and team, to give us the update.
Good afternoon. Javier Aguirre with the Office of Diversion and Reentry Services. Right is Chad Martin from our office. Before Chad will start the presentation, for us to acknowledge the 248 women that are both they're at Elwood. Work that we are doing with the collaboration of the Office of the Public Defender, the Office of the Sheriff, the Office of the Women's Policy, Office of Pretrial Services, Probation Department, Behavioral Health Services Department, Custody Health Services, and our community partners. We are striving our best to assist the individuals that are in custody, and we've been able to create a justice system involved women framework. And we're excited that all of these partners will be convening in March and a retreat to further discuss and support the many initiatives that the county is undertaking. So with that, I'll turn it over to Chad, who will do the presentation.
Is the mic on?
Yes, there you go.
Thank you. New mics. Good afternoon, Reentry Network members. So just some quick background on our work with women in custody. We came to this body in June to give you a proposal and tell you about our new structure to serve justice-involved women. So just a reminder, there was the executive committee that handles the bigger picture, assigns staff to the work, and then we had the existing gender-responsive collaborative, and we are still using that group to really narrow down on next steps, challenges, and increase access to services for women. And then we've also brought in a case conferencing group, a Women in Custody case conferencing group, also called the GROW case conferencing group. That group is really, we meet every 2 weeks to get a list of women in custody, and we go down list, women by women and discharge plan. So when it comes to that discharge planning effort, the Women in Custody case conferencing, there were 99 women reviewed in custody, and 20 were still in custody at the time of the review or the analysis. And we have a breakdown there on the left for you. As you can see, 7 women still had a plan in progress, which means they either hadn't been engaged or reviewed yet, or they hadn't signed an ROI but had a plan in place, or maybe they didn't need a plan or they had a separate plan outside of that body. When it comes to the actual releases themselves, there had been 79 releases as of mid-January, and again, that's broken down on the left there. When it comes to behavioral health releases, most of the women were released to the STEP program, and that's really wraparound support, getting them linked to treatment beds, and making sure they get the clinical support they need. If the women don't need clinical support, we send our service navigators, our contracted service navigators in, and they actually go in and meet with the women and engage with them in custody, assess them, and discharge plan. They focus, a lot on the transitional aspect, but they also case manage them or keep them on their caseload for a few months and provide them additional resources as well. Women who aren't eligible for the service, you can see the 11 there listed, or 14%. Those are usually women who had pending criminal matters in other jurisdictions, so they're being released to a different county, or they're moving at release, so they couldn't have a discharge plan in place. And then there are the ones who we had an unknown. Most of the unknown, the 16 there, were from the early iterations of the case conferencing. So we expect the 20% to decrease as releases increase. And then some of them also declined to sign releases of information. So they did have a plan in place, we just weren't able to identify the exact plan. So when it comes to the gender responsive collaborative, we've made a lot of progress on that front as well. Going back to case conferencing, it's become more streamlined. We have a better ROI, or release of information, in place to allow us to case conference better. But the goal here is continual improvement. And so we look forward to the following meetings on that. And as Javier mentioned, we're going to meet in early March to have a retreat, and that's going to really finalize the GRC work plan. But these other issues are things we have kind of flagged to address. And then there are other issues or challenges as well, such as, or other initiatives as well, such as library services and custody that the programs unit is working on, and dignity backpacks that Office of Women's Policy is working on. One of our main challenges is engagement. A lot of the women are accepting services and getting release planning, but some of the women are more reluctant to engage, and so it's really about building trust and motivation and encouragement. Finding the right staff to go in and outreach and present, in addition to the staff who are already going in. And then housing and transportation and clothing. Housing, as you know, is a challenge, but we're looking at options to streamline resources that we have currently and expand where we can in the future. Transportation, we have an RFP being finalized to provide a shuttle service, but the providers also provide transportation as well when they're working with the women. And clothing has been provided for a while, but there's still room to streamline that and get things consolidated there, especially when it comes to things like maternity clothes or unique situations, which we've been successful with, but we're keeping that on the radar. And then when it comes to mothers or women with family reunification needs, I think that is something that we've been discussing, and we've really encouraged providers to also address that at release and during discharge planning, so that they can flag that and get the women referred to providers like our DRS Family Law Services, First Five, and Department of Family and Children Services. And then finally, data sharing. That's something we've been working on. We've made progress. We have an automated list now to generate the list of women with known release dates. The challenges here are more cross-referencing data sets because of the legal challenges and staff resourcing challenges, but we are continually working on that as well so we can report a more comprehensive picture for you all. And then finally, we just have a kind of a high-level visual way to look at the different intercepts, if you will, where people or women are being assessed, getting services in custody, connecting to services in the community. It's not a comprehensive look, but it's a tool that we're using to identify gaps and facilitate discussion. And with that, that concludes my update. We're happy to take any questions.
Great. Do we have any public comment?
We do not.
Thank you. I'm going to close the public hearing and come to my colleagues, and I'll start on this side. Yeah, Nick.
So, thank you for the report. The women that we have currently in custody, and I saw that there was some reference to mothers. Do we know the percent of women in custody who are mothers or who are pregnant at the time that they're in custody? And then are there referrals to a physician? Do we know, do we make sure that they have a physician when they do get released, and that they're making those appointments? When we talked about medication and things and having a script, do we know that women who are pregnant have a physician and they're being taken care of when they're in custody, but then when they leave, are we making sure that there's a physician that they're connected with?
I think for that question, we would like to defer to Dr. Day to see if the women under her care, the percentage, because
Dr. Day, can you put your mic on?
Sorry about that. Catherine Parlett is our subject matter expert, but we have partnered with the prenatal health in the community and are doing a work group together with them. So Catherine could expand on that as well.
So there are actually not that many pregnant women in the jail at any one time. I would say like the last time we looked, there was like 7 pregnant women, which was very high, and that's a very high number for us. Of course, we have a OGBYN who sees these patients and refers them out if they were not to give birth within the jail facility. Of course, they go to the hospital to give birth, but in case we don't have them all the way through their pregnancy.
So, and your mic's a little hard to hear. I'm sorry. I know these are, they fix them and they just, I don't know, they're a little gremlin-y. But what you're saying is currently you have 7 women who are pregnant in custody. The question I think that Nick was asking is, so we have a pregnant woman in custody and she's leaving before she gives birth back to the community. What is she provided with relative to her health and the health of her unborn child?
Of course, we have all these women seen by our OGBYNs, and they refer the patient out for continuing care upon release. We wouldn't, ever release a pregnant woman without giving her services. As a matter of fact, we recently had the perinatal and the Black Infant Health Program present to our staff and explain those resources. So if anyone of African ancestry were to be pregnant in our facility, we could refer them to that program. We have an extensive list, about like 100, I want to say it's like a 124-page list of different resources for pregnant women within the county of Santa Clara. So we have a lot of resources to refer these women to depending on the kinds of services they need.
So Morris, oh, go ahead, Dr. Day.
I can speak to that as well. And our OBG is from Valley Medical Center. And so they bridge the patient back. If they are still pregnant while released, they bridge them back to Valley Medical Center to continue their prenatal care up to birth as well. And so the OBGY that we have in-house is coming from Valley Medical Center to see our patients, and then we'll bridge that patient back to Valley to continue to follow.
Nick, did that answer your question?
Yes, and I mean, I'm glad that we do, and then it becomes about the follow-up. We can refer people as many times as we want. It doesn't mean they're necessarily going to go, and that you know, for those who are being released on probation. That's on us, and we need to figure that out, and I'll certainly check into that. We know that women are the caregivers of all these families, and we have women in custody. And so we know that when we talk about housing, as it was mentioned here as well, are women with children, are they at the top of that list? Do they just fall where it falls? I mean, just some things to think about and to look at for the women who are the caregivers for every family out here. So just some thoughts.
Did you want to jump in on that? I'm gonna turn to Supervisor Ellenberg, and then I'll opine. Go ahead.
Okay.
All right, Wayne.
Nick, I appreciate your question, and Dr. Day, thank you for being specific about the connection made, handing a woman leaving custody a multiple-page list of people that she can then, or she must on her own, then make contact with, I think is a little bit overwhelming and reduces the likelihood of contact, of continuity. But if the OBGYN in custody is specifically connecting the women to a physician, an OBGYN at Valley Medical, and making that a very clear and simple transfer, it would seem that that would have a higher likelihood of success.
Correct.
Question mark. Thank you. And then the other question, Nick, that I thought I was hearing as well was moms with kids, caregivers who I understand that we don't formally ask if women have children when they come in. When I was on the Commission on the Status of Women and a jail monitor, we did a couple of surveys over the few years that I was there, and both times about 70% of the women that were in custody had children. And certainly getting access to housing is often a prerequisite to family reunification. So I would like more information to understand whether they are prioritized. Your question, I don't know the answer to that either, but I would think that that's, again, absolutely in our interest for the benefit of the children as well as the parent to prioritize their reunification wherever it's possible. I mean, as quickly as possible.
And it was highlighted here, and the unplanned releases and then the numbers in the jails are just enormous, obviously, than in the juvenile world. And that's a problem even in the juvenile world. You know, when all of a sudden a youth goes to court and they get released, everything is lost. Education, there's no planning for a lot of that. And I can only imagine on the adult side with so many more to think about when the medication and when the women, when they're released, how far in the process with the doctor or the physician were they at? There's so many barriers that we miss when people are just released, and we should release them when they're eligible. But it is a barrier. I mean,
It sounds like this is the problem that we need to solve for, that
it's
since
hard.
that's the majority of our releases.
Yeah, and it's difficult because there's so many assessments that go on with folks in custody, and it's a step and it's a process, and then they're gone. And so then where's the connection? They've lost all that they've gained while they've been getting these assessments, and then what? You know, and it's difficult, and I don't know the answer to that, but it's something I think that we should keep in the forefront of these numbers of folks who are released without anything just because it was their time to get out and they went to court and they're released.
You know, did you want to weigh in?
I just want to say that I was ready to miss Laura so much, and I'm just so glad that you're in this seat. I had another question, slightly unrelated. But
Can I take this one, and then, but then we'll jump right back. I mean, I think on this point, just since you're having the retreat in March, one of my questions was going to be, who are all the participants? And I'm presuming that retreat will include probation and someone from Dr. Day's team as well, and obviously from the sheriff's team. So I say that because I think these two questions really need to be wrestled to the ground. And then the other is that I just want to reaffirm that we're not asking when people are in custody whether or not they have children, you know, on their intake. And at least somebody told me that at some point. Is that accurate, or do we actually ask if people have children when we do intake in the jails?
I would have to confirm that, but when they do the psychosocial, they are asking those questions about family dynamics, children.
Was that what you were going to say, Matt?
And it's not any sort of required question, just like the pretrial interview is not, but we do ask if they have children under the age of 5 or under and what their ages are and
So-
genders. And then that is a referral that goes to
First
family
five.
First five, yeah.
So one thing, again, add this to the retreat, but I don't understand exactly if, one of the issues that we've been talking about is family finding, like reconnecting people to their families and as quickly and as healthily as we can. And I know by the time some people are in custody, they've burnt a lot of bridges. I've been told that, and I get that. But I think having a robust knowledge of who we have in custody should require us to ask the question about family and to know the answer to that in a much deeper way. And so if that could be included in the retreat, and then I'll talk to the folks who do booking more about that and intake, I think that's really important. A big part of the work we've been doing in SSA, as Deborah knows, is really looking at family finding as a core component of the work that we're doing. But I also think it gives us a perspective on how, like, who are we getting and why in our jails. So I'm going to ask if that can be discussed in the retreat, and then ask if that's something that the sheriff and booking can take a look at. Nick, did you want to weigh in on that too?
Sorry, just one more thing.
No problem.
And sometimes it's the question we're asking. I mean, do you have children or do you care for children? Because there's many families where I'm caring for children all day long, but they may not necessarily be my child. And so it's how we ask the question sometimes to glean more information.
Yeah, I think that's a really, really good point. All right, I'm going to go to Susan, and then I will go to Molly.
Thanks. At the December PSJC meeting, we heard from the Community Corrections and Law Enforcement Monitoring Subcommittee a recommendation that the county address the disproportionate number of grievances that come out of Elmwood's women's facility. And the sheriff's office reported that the best way to address this was through the work that the Moss Group is developing a proposal for, and that we would be getting an update in January. I just wonder if you can give me an update on when we might be able to see that report. And I realize you're pulling things together, so this may not have been at the top of your list. And what I'm really wondering about also is how the Moss Group assessment lines up with the work of the Justice System Involved Women Framework.
Yeah, great question, and I'll have Assistant Sheriff Sepulveda address. But the Moss report, actually, I just had a conversation about that and a request to have a summary presented to me because of my newness, so I have a better understanding of the work that's being done, and that request is due to me Friday, in fact. If I had known this calendar, I probably would have requested it for today, but I didn't at the time that I made that. But I don't know, there's Laura McCabe, maybe she can answer a question.
So we had to adjust the contract with the Moss Group. I just got the contract back. We are meeting early next week to discuss the rest of the work, but we do have their proposal, and it can be discussed further during the Public Safety and Justice meeting next week.
Thanks. And can you say anything about how and if it lines up or intersects with the Justice System Involved Women work?
I don't know, but we can certainly take a look.
Okay, thank you.
Yep. That's a great question. That's the point of the retreat. So we
Right.
want to align the
Excellent.
Moss Group, and we were planning to ask all of our internal stakeholders to identify their top priorities, because I think there was 60 or 70 different recommendations in the Moss Group, and then we'll be able to align with our work plan. So, and just going back on the question about the question that we asked the women about if they have children, part of our service navigators, when they're assessing our clients, they do ask that question and they do the follow-up. And so in that, on the last slide, in terms of the assessment, that's something that we will then kind of look at all of the various assessments that take place, and we could pull that question out if they do ask and then follow up with this committee.
Thank you so much, Javier. That's exactly the information I was looking for.
Go ahead, Molly.
Thank you. I had a general comment and then a question for you, Chad. My comment is, we have releases happen all the time, 24/7, but we have services sort of only in place Monday to Friday or 9 to 5. And so I believe Dr. Day mentioned they have 24-hour coverage with discharge clerks Monday through Friday, but we don't have them available on the weekends. And we've talked a lot in this committee about women being released in the middle of the night and walking long distances. And so we have, and the reentry center, I think now has some Saturday hours, but is generally speaking closed in the evenings and on the weekends when we still have people being released. So that's my comment. And my question was, on the RFP for the transportation, will that include evening transportation services for people being released at odd hours?
That's an excellent question. Thank you. So that's one of the challenges we've been struggling with. In the solicitation, we did ask for a plan for after hours. I think our current challenge is destination. Where do we take them if most services are closed? And so that's kind of what we're hoping to flesh out more when we receive the proposals. This initial phase will be a one-year kind of pilot to figure out, how to streamline things and how things are working, and then from there we can build upon it. For women in custody, especially the ones through this case conferencing group that have who are sentenced and have known release dates, we're really focused on getting them connected to a provider because they will meet them at any time and they will provide Lyft or they'll come pick them up themselves. And so that's something that we're trying to fill the gap with in the meantime. But as you can imagine, it's hard to get that resource to everybody who's being released.
And if I may, I add Elmwood on Mondays through Thursdays from 7:30 p.m. to 10:30 p.m. The faith-based collaborative have a resource table, and then also on Wednesday mornings from 7:30 to 10:30 a.m. And then in terms of the faith-based having that resource tables, when I asked about how many calls, because they also have after-hours calls for individuals, and after 11 p.m. they've only get about 2 calls per month. And then one last thing too is Custody Health can utilize and refer clients to the Mission Street Recovery Station. So if they identify any individual in custody that doesn't have a safe place to go after hours, they can make that referral to the Mission Street Recovery Station. The staff at the Mission Recovery Station can then use their van to pick up the individual from Elmwood or walk them over from main jail to the recovery station.
And I'll just add to that point that the last item we're going to talk about today is around a release, how people are released. And the one thing that I would really like to end up with is a bit of a working group to have a conversation with the sheriff, with the courts, and with our reentry center and our medical team so that we can have a deeper dive into strategies for release, because we've been kicking this around and other facilities have figured out how to do it and we haven't, and we just have to fix it so that we're able to align resources better. And so I was going to mention that at 5, but thanks for all right. Anybody else over here? Judge Manley?
I was just going to bring up another service that's now available, and that is the enhanced case management, care management. Now, that is a Medicaid-funded service. It provides navigation, in-person engagement, and that is in place now. It's been in place since, I believe, July of 23. I think it's January of 23. I think it's in place now. And I just am hoping that when you have these retreats and you have these discussions that you take advantage of these new programs that are available. Because I really think that enhanced care management is really going to make a difference. It's a whole different approach. And they're not allowed to go into custody, but it is a way to bridge to get the navigation, to get the person connected with treatment and services. And I just hope that everyone considers that, because I know that both of our managed care plans have reported to the state that they are ready to proceed. And from the information I've received, we have one enhanced care manager position in behavioral health. And my suggestion is that go for as many enhanced care management positions as we can get because we have the people who need them. And since we don't have to wait for another year to do that, that seems to me to be something we ought to be building in now, right away.
Is that
Just a suggestion.
Is that happening already? May I ask staff? Does anybody know the answer to that?
We are utilizing ECM through the managed care plans to provide, well, we are using the managed care plans to provide ECM services to a variety of populations. I think we have some positions available for this group as well, but we do need to bring it, sort of try to flesh it out a little bit, make it more robust. And Michelle De La Calle from Office of Systems and Integration Transformation is here. Maybe, Michelle, you can provide a little more detail?
Hi, good afternoon. We do have enhanced care managers in the medical system based on they transition from the whole person care pilot prior, and in CalAIM they are, we have a broad range. We have about 1,000 people enrolled that we provide direct services to, and we partner with our managed care plans. We're trying to look to expand that. The one ECM pilot that we have with behavioral health is actually working in with Robin and Gabby in the courts, and we're looking at how we can spread that kind of model beyond that one person. It becomes complicated with funding streams and capture of data and information for reporting structures. To get the reimbursement for the ECM. So it is more complicated than simple, but we are actively pursuing the infrastructure to build it in deeper into the behavioral health population.
I'm not sure I understand exactly, Michelle, what you just said. So I'm going to maybe ask it a more simplistic way. So we have one person filling that job, a role right now for our population that's in custody.
No, that's not accurate. We have one person currently in the courts working with Gabby and Robin's team and Judge Manley's team that is testing that process for that particular system. We have about 20 case ECM providers throughout the primary care setting. So where the person has primary care, they would have their enhanced care manager assigned via that route. So the population that's served through ECM in our current programming is based in the primary care setting. This is our first pilot setting in the behavioral health
And
proper.
so we could put them in, we could have that same position in the jails through Medicaid funding today?
In court.
I'm sorry. Oh,
It's
so you have one person now, Judge Manley? Yeah. That's what she's saying.
Yes, we have one.
Okay, so you have
person.
one.
And so what I'm proposing is that, and I understand you have to check, work it out with the pilot, but I think the idea of enhanced care management is that you would have enough enhanced care managers with small caseloads to take care of the entire population.
Got it. I hear what you're saying.
And it's paid by Medicaid dollars.
Got it. And I understand the point now. And so you're working on it.
We are actively working on
Okay.
on expanding that. The custody involved population as a specifically designated population of focus does not go live until January of 2024. That said, several of the populations that come out of custody may meet other criteria.
I totally understand that,
So-
and I see what you're doing.
So we're
You're
taking that
jumping in
approach.
now because we think we have enough people that are coming through that have other opportunities to draw down the resource.
Correct.
And laying the groundwork to be able to turn it on when we can.
Correct.
All right, great, thank you for that. All right, I'm so sorry, I keep skipping.
No, it's okay, I'll just impound your vehicle, but that was a joke, everybody, just so we're clear. But I'm going to reserve my question for one of the future items.
Okay, thank you. Cora?
Yeah.
First of all, I just wanted to acknowledge the county. I think that with the array of services that we have, we're in the game, right? We're doing well. Where I sit, I see the problem as the communication issue between those services, between those programs, and also from the programs to the clients, okay? I know that we're trying. I know we're trying very hard. And we're getting there. Having said that, though, I have a question regarding the pregnant women in custody. And I know you said it's a small number. Because of the fact that they have different needs, both physically and emotionally, are they housed separately? And how do we make sure that when they are discharged, how is the handoff to the reentry? Do we have a process that does that, or is it the same for everybody?
To respond to the latter question about the discharge, so my staff works closely with the behavioral health staff, custody health, and the sheriff's rehab officers, rehabilitation officers to make that warm handoff. So the individuals that sign the ROI, release of information, and say they will participate in the gender responsive collaborative and grow, we have that communication. But the individuals that, remember, this is voluntary, so they're not required to do engagement with us. But those that do, we do have that warm handoff.
Okay.
Thank you for the report. And I think at the next quarterly report out, you'll have had the March retreat. I'm sure probation's going to be involved. I'll look forward to both seeing who participated in it, as well as what the work plan looks like. Even if it's a draft work plan, I feel like we just need to get in and make some choices about starting. So I'm going to say work plan with whatever the top priorities are that the group could agree to. And those that the group couldn't agree to, you know, I think the board would be interested, I mean, the committee would be interested in understanding that too, because there may be other ways to address those issues. All right, thank you very much. Appreciate that work. And let's remind ourselves that we also want to be able to track and study recidivism based on our ability to really invest in people.
Absolutely.
So thank you. All right, so we're going to move on now to item 7. This is the collaboration between autism to receive a report relating to jail diversion data and system improvements for individuals with executive function disorders, specifically autism, spectrum disorder, traumatic brain injury, and fetal alcohol syndrome. And so I think with this one, I'm going to turn it over to Michelle and team. Great. Welcome.
Great. Good afternoon, Supervisors Chavez, Ellenberg, and distinguished Reentry Network members. Michelle De La Calle, Director of the Office of System Integration and Transformation. With me today, I have Dr. Wee No and our Program Manager, Sally Lawrence, who have been leading and supporting the integrated care team working with the executive function disorder population. You have your written report, and we have a brief presentation for you on the care delivery pilot. The team continues to work in collaboration across custody health, behavioral health, and Valley Healthcare, and we remain committed to the learning process and collaborative nature of this work. The integrated care team is entering the test and optimization phase with executive function disorder population, or EFD. They continue to learn about the population, the gaps, the needs, and are focused on engagement, enrollment, and interventions. The team can now directly see how the patients with executive function disorder experience challenges in attention and effort, impulse control, planning, activity, shifting memory, organization, and mental flexibility. These challenges add a dimension of difficulty that the patient must face in the navigation of multiple systems. It can lead to unmet physical, behavioral, and social needs, and potentially repeated justice involvement. Family engagement may also be negatively affected. The team continues to test and optimize interventions while considering additional inputs so that they may develop a clear clinical picture to optimize the workflows. Ultimately, the goal is to make recommendations to scope and scale the program. Sorry, this is going too fast. All right. The nature of the cognitive impairments for those with EFD and the lack of diagnostic visibility and the variable systems in which the documentation may exist has been confirmed in the work done so far. This further clarifies the need for a multi-system perspective to understand the full picture of the patient's health and how to address the gaps in service and care. Depicted here is the service workflow that has been developed to date. As we finalize our full complement of staff, the team has focused on the comprehensive multi-system chart review. This work has been laborious, and with time, the team has found the right mix of information to help us determine the factors to help guide us in our work moving forward. Outreach and engagement is in progress as well, and with some noted success. This is a complicated summary here, but we believe it really reflects the information gleaned from 5 systems used to get a holistic understanding of the population and the focus of the work. In a collaborative process with compliance, privacy, and with training, we've been able to compile this data on a small subset of the population, which we think shows the value of the work and some of the common challenges the patient population face. Of note here is that even with this, there remains gaps in information, and we're currently working with county and non-county education partners to support additional access to educational information, such as a 504 plan or IEP. Our collaborative partner in this work and expert, Dr. Robert Land, has also encouraged review of attendance, behavior, psychological testing, and other school-based information as well. Although anecdotal, the team has had some key outcomes to report on individuals that have engaged with our team. One client was successfully enrolled in healthcare coverage and reestablished SSI income. They were also able to stabilize their mental health and access to the right treatment options. Another was successfully placed into stable housing at a board and care. Here's yet another view of how we see our program doing the work with the population across the continuum and building solid pathways into the community. To reach optimal health, every patient deserves the right to access high-quality service, and the team strives to connect the patient to the service that fits their unique needs. Through the extended warm handoff, our team will support the connection to the services needed by that individual patient. Knowing that each individual will have a unique set of needs, this model can be applied to any branch of the care delivery model that is needed to provide the highest level of quality to the patient. What we're calling the extended warm handoff varies from the standard warm handoff in that the care team will provide a longer period of time with an additional layer of support from the team and can ensure that there's a clear understanding of the plan of care, secure support in the settings of care, and a mitigation plan if there's unanticipated change or regression, like a missed appointment or justice involvement. The care team would then step back in to support additional stabilization and care engagement. According, again, to Dr. Land, who is not able to join us here today, this extended warm handoff can be a game changer for the population with executive function disorder. They may downplay their needs or be resistant to or forget their appointments. And when considering FASD patients, they may at times exhibit confabulation or cover up, as it may save face or cover weaknesses. We know that there's a better way. At our last report, we were asked to talk about engaging families. So far, the team has engaged families as early as possible when conducting outreach or working directly with the patient. In fact, family has been a critical source of support in successful outreach. This is especially true when the patient is unhoused, as family may know the best place to look for the patient in the community. As with all unique patients, each family is unique and has variable levels of engagement, and all levels of engagement are welcome. Family members willing to engage with our team have received education, service referrals, availability for services, advocacy, and emotional support. We anticipate this to be a fundamental part of the scope and scale recommendations as more information is obtained in the pilot in partnership with community-based and family-focused groups. As an anecdote, one patient's family member called the team about their family members' increasingly aggressive behavior in their care setting. The behavior had put the individual at risk for losing their placement and going back to the streets. Because the family reached out, and because the team had done this deep chase review of the chart, the team was able to communicate a previously successful intervention to the facilities team, and as a result, the behavior improved, and the patient was able to keep their current placement, and housing has been maintained. So, what does 2023 look like for the integrated care team? You can see some of the items here, and we anticipate to present a more transparent work plan in the next update. Of note here is that we will launch our youth and transitional youth focused outreach based on data analysis and relationship building. We also need to better understand the breadth and depth of the gap in diagnostic visibility while maintaining compliant privacy standards. Both of these will require ongoing partnering with family and county and non-county partners with similar interests and work focus. Before we get to questions, I want to take just a moment to recognize our partner, Sally Lawrence, program manager, who's going to be retiring next month after 13 years of service with the county and 6 years with our office at the Office of System Integration and Transformation. For the last year, she's really stepped up, taking on this particular program, and has led with compassion, competence, and commitment. Through the work, through the team that's been developed and the stakeholder engagement, it's a testament to the value she's brought to the community at large. So we want to thank you, Sally. And with that, we're here for questions, and we have other team members here as well.
Great.
Thank you.
Thank you. I'm going to first see if we have any comments from the public.
We do have one.
Great.
Great. Paul Soto, if you come to the podium, you will have 2 minutes.
Paul Soto from the Horseshoe. I think one of the things that we have to acknowledge as a community is that we're trying to humanize a system that by design dehumanizes. So we have to accept that fact. And this isn't pointing fingers at anybody. As a society, we have created this. And so what are we going to do as a community to humanize that which we have designed to dehumanize? And so this is why this tension that I referenced earlier has to be raised to the level of consciousness. Because once it's raised to the level of consciousness, then we can have a very human response to human suffering. And that is that we don't look at it with indifference. The culture that's been created by society in the jail systems is designed to dehumanize. Criminal, the names that we use. These are criminals, and the one that really has bothered me, and I will never get used to it, I'm glad that I will never get used to it. Whenever a guard is referencing somebody that's in a cell, they don't call us people. Or, hey guys, come here. No, the guard will say, how many bodies are over there? How many bodies in that cell? There is only one other space in a community where a human being is referenced as a body. The morgue. A human being that has no soul anymore. It's gone. So this doesn't do anything to us. Yeah, we experience the pain of the dehumanization. However, it does something to the guards. It does something to the culture. What it means is they give themselves permission to reference us as bodies and not people and human beings. So we're trying to amend that, and I'm willing to participate with you in that process. Thank you.
Thank you. I'm going to see if there are any questions or comments. Christine?
Thanks. Thank you for your report. I really am grateful to have you all here and to see all the work that you're doing. I've been delighted to be part of the FASD collaborative since its conception, and it's just thrilling to me to see this coming about. I know that Dr. Land has been really delighted to work with you, Dr. No, on expanding just the knowledge of what FASD looks like. And of course, one of the problems with FASD is it's not as easily diagnosed as autism or TBI. With those, you've probably got some valid screenings that can be utilized at booking or in your clinic or anywhere else, or a school record that says this guy has an IEP for autism, this person has had a TBI when they were 8, or whatever it is. FASD, as you know, is far more elusive, and there aren't any really good, valid screening tools for us to interject anywhere. So one thing I just want to float is, let's make one. This is a very innovative, skilled valley. We're known for that. And we've got incredible partners in the justice area, along with behavioral health and medical. And I think, let's make our own. Let's make one that works so that we can find these folks. And the other thing I just want to stress is that the frontline people that are going to come in contact with people with these disabilities or conditions, especially FASD, really need to have enough training to be able to recognize it. It's not that they're being willfully, it's not willful misconduct, it's that I don't understand what you're saying. Whatever it is, there needs to be a lot more training for the people that are going to be on the front lines, and these are, law enforcement, people in the hospitals, the security guards you're going to put in the libraries, et cetera. All those folks need to know how to be able to recognize these conditions so that they can divert them appropriately rather than us finding them in your clinic because they've cycled in and out of these systems so many times. So I just want to champion more training for anyone that needs it that's going to be on the front lines of meeting these citizens out in the community. But again, thank you so much for your work. I'm just really excited to see it all unfold, so thank you.
Thank you.
Thank you, Christine. Dr. No, did you want to weigh in on her thoughts?
Good afternoon, supervisors and Reentry Network Committee members. Thank you for the feedback and comments. The scope of what we're trying to do here it's amazing. This is a population that before we started this work, I did a deep dive into existing programs around the country addressing this specific population with FASD and ASD, TBIs in a custody justice-involved population, and there really isn't one. And so there's so many kind of workflows and just system gaps that we're identifying and also trying to find ways for solutions. The screening that you mentioned, we have something in the works. And so the idea is to implement this across the patients that we work with. And there's a number of other things, including the sort of education, I think awareness within our system. And part of this, what we've done so far is by having experts like Dr. Land and others, they've given talks for our team members, which we hope to create into something that can be more systematic in building the awareness and for all the workers here. So thank you.
Thank you. Judge Manley?
Thank you. I've really enjoyed your presentation, and I commend you for the work you're doing in this area. I can tell you for many, many years, one of my greatest frustrations is that when I have individuals who are in custody and have a traumatic brain injury that everyone agrees that it's there is nowhere to refer them, nobody to pick them up, no one to take them. They don't do well if they're just released to the streets. I know that because I see them again and again. So my question is now, you're doing great work. Is there a point of referral now? Because I'm often told that TBI, for example, is not mental illness. It's really not in behavioral health. And I should look to Valley Medical. So what I'm looking for is there a referral? Do you have a list of agencies or programs that will take individuals who have these executive function disorders that we can refer to from the court?
Judge Manley, thank you for the question. We do have a referral system. We're starting with working with a psychologist at the custody, and from there we'll branch out and scale out the referral system.
And you'll let us know.
We'll let you know
Thank you
for
so
sure.
much.
Any other comments or questions? I just want to say I'm thrilled with how far you've come in such a short amount of time. And I really want to thank Christine and other community leaders who really put this on our radar, and then you all responded. I think that's wonderful. I would be very interested in understanding what we can refer, where somebody with this high level of need can be referred in the community. Like, what are the community resources? And the reason I'm asking that question, and I'll just mention this through Key, I think the point about, I think one of the challenges we have is that we can't have a medical department that's arguing with our behavioral health department about who's responsible for somebody. And I know part of that is just, it's not a blame thing. It's really the way everybody's trained. You're trained in a medical system and you're trained in a behavioral health system, and this falls in this particular area. I, for one, would be very interested in the referral for placement, and am interested in understanding if our behavioral health contractors, if any of them, have the capacity to be long-term placement for folks who fall in this category. And I know we're going to be, since you're doing that RAND study, in some ways, this is a population that's not easily going to fall in or out of that study, but that might be an opportunity to at least take a look at what is available and what may still need to be invested in.
We can certainly use the RAND study and work with the team here to sort of identify sort of where these individuals with these needs might fit the best, and then sort of begin to sort out what we can do and implement over time.
That would be great. And then on the training function, I want to just make a plug for better understanding long-term how the training is happening in custody, for one, in terms of helping our rehabilitation officers and our custodial officers to understand how to interact with folks in custody. And I'm sharing that with the sheriff since they're his team. The other, though, I'm really interested in understanding is how we're using the work that you're doing in this environment to spread it through the rest of our medical facilities, all of our hospitals and all of our clinics, because certainly this is something that we'd like to catch sooner rather than later and then resource appropriately. And I recognize this also has a challenge with SARC and other places, but the more data we have, the easier it's going to be for us to make the case for changes in state law, which some of this is what it's going to take. So, when you come back with the next report, and also hopefully with the work plan, these pieces can be laid out so we all know what our jobs are. Thank you very much. Seeing no others, we're going to go to our last item. And colleagues, I always mean to manage these meetings better, and then I get so interested in the topic, so I will do better. That's was on my New Year's resolution. So our last items to be heard together are 8 and 5. So if I can ask the teams that will be presenting on both of those, and I'll just ask for the indulgence of my colleagues to maybe about 5 after 5. And Casey, are you kicking this one off?
So Supervisor, I'm presenting item number 8. I'm happy to go first if you'd like.
Yes, that would be perfect.
Okay.
Yeah, I think it just creates context for the
Sure.
discussion on 5.
Okay.
So what I'd like to do is have 8 and 5 present. We'll hear them together as I alerted folks earlier, and then we'll hear the presentation, go to public comment, and then get feedback from the group.
Okay. Now, Supervisor, would you prefer that we go through all the slides, or in the interest of time that we go to questions? It's up to you.
Oh, no, slides, just go ahead.
Okay,
I need to
great.
be focused.
Okay. So Casey Halkin, Deputy County Executive, and I'm joined by Program Manager from the CEO's office, Melanie Jimenez Perez. I'd like to offer her a big thank you for all this data collection, and also to our team at Pretrial Services, Dean Yamasaki and Julie Bork, who did a truly fantastic job. So just a brief overview. So this is our first quarterly report to REN with data from 2022 with an emphasis on Q4. So our data concludes December 31st of 2022. We will be doing another report later in 2023 on our first quarter. Just for everybody's awareness, this information will also be presented and is presented quarterly to PSJC as well. So for some of this you may have seen, this is a repeat. So this is an overview of our monthly jail bookings, and there's a reason why we went back to 2019, which is, of course, prior to the pandemic. We wanted to illustrate two data points that were captured. If you look at the significant decrease at April 2020, that's of course the declaration of a pandemic, and you'll notice that we had a significant decrease in our monthly jail bookings. And then also you'll look at, there was an uptick in April 2021, and you'll notice that that's when we started to see a slight uptick as people came a bit out of shelter in place. And then also in July, you'll see a slight uptick in July 2022, which was the conclusion of $0 bail. And so those are high points for those of us in the criminal justice world in terms of looking at some patterns from our bookings. So our bookings have not returned to pre-pandemic levels, which I think is something to note. So the average jail population, our average on the month, so this is the same time frame as the previous slide. And you'll notice that we have a gradual increase May through October, and then a decrease in November and December, which is following typical seasonal patterns that we see in crime rates and have seen for several years. So this slide overlays the bookings and the average jail population to kind of provide a sense of which crime types are coming in and out of the jail and who remains housed in our jail. So through Q1 and Q3, the bookings and the jail population closely follow the same trend. But if you look at Q4, you'll notice that the bookings are going down, but the jail population is not following that same trend. And so this anomaly is something that's been noticed by many county departments, is impacting many county departments, and it's likely due to the court backlog. So next week at the Public Safety and Justice Committee meeting, the District Attorney's Office will be doing a presentation on the court backlog. And I imagine that this will be a topic of conversation for our public safety and justice partners as we look at how to try to reduce our jail population safely, and also how to try to get through the adjudication of some of our older cases. So this slide overlays our releases. I know we're going to talk about that a little bit in more depth in item number 5. So our numbers will look slightly different from the sheriff's office because we are looking at all releases. So not just releases out, but releases to programming, releases to state prison, releases to rehab. So you'll be able to see the bookings, releases, and our average jail population. Again, that population is not going down with the trend of some of the other numbers that we see. So these are some snapshots from the 15th of the month to give you an idea of our average length of stay. You'll also notice, I think, that 3-year plus, which we'll talk about in a little bit more detail in a couple of slides, but that number is increasing. And this is, again, likely due to the court backlog. We have cases, older cases in particular, many of which are serious felonies, so homicide and sexually violent crimes. And these cases are taking longer and longer to make their way through the system. So the county is working on the stress test as a result of the consent decree, and we anticipate that that is also going to come up with some strategies for how we, as a population of criminal justice stakeholders and community members, can work together to collaborate to try to address the jail population and also the slow adjudication of our cases. So this slide will indicate for you, and it's a little bit challenging to read, so I can certainly answer some questions if people have it. But this is the overlay of the felony unsentenced and misdemeanor unsentenced, felony sentenced, and misdemeanor sentenced over a period of time. So you can see the fluctuation in the populations for certain categories of offenders that are in our jail. So while there are slight variances, what this indicates is that most of the jail population is unsentenced, and over time, they're becoming mostly pending felony charges. So we've heard the sheriff's office talk about this in the past, that the nature of the jail population is changing and has changed significantly over the last several years. So we have way more felony pre-sentenced individuals in custody than we used to have, say, 5 years ago in terms of a percentage. This is another way of looking at those trends. So you'll notice that the population of the jail is consistently high and is going up, where other indicators are getting lower. But it's the felony unsentenced, which again is likely due to the court backlog because those cases aren't being adjudicated, and then also the population is going up. So it's the same trend over time, which is that the jail population is not going in accordance with our bookings and our releases. So this indicates what types of charges, the booking charges snapshot that we have for the 15th of every month. And so at each snapshot, the top 5 and highest categories are violence against a person, property felonies, sex felonies, misdemeanors, and felony theft. But you'll notice those top 3, violence against a person, property, and sex felonies, tend to be almost equal or within a certain variable, but they tend to be the top 3 that we have booked into our jail in terms of staying in custody. So this is one area that the stress test is really going to focus on as we're looking at the individuals in custody without a release date for 3 years or more. So we have 161 individuals, and again, this was of December 31st, 2022, who have been in custody for 3 years or more. And you'll notice that 97% are male, 3% are female. Of our 3%, that's actually 5 women, and 3 of them were booked on a homicide felony and have multiple dockets. One was a burglary or a property felony, and another was a violent crime against a person. But of the 161, we have the 15 who've been in for much longer, sometime between 2009 and 2015. Again, this follows the trend that we've been hearing, which is that the population within the jail is changing. So the individuals in custody without a release date sort of mirror the general population that is rising in the custody setting, which is more violent crime. So 39% are homicide-related felonies, and 37% are sex-related felonies. We took a deeper dive at the 15 of the 161 individuals that have been in custody, some since 2009 or 2015, so somewhere in that period, but a significant amount of years. All of them are male. The highest charge and most related is homicide. You may see those charges where there's multiple offenders in one case. They average 3 dockets per person, so these are offenders who either have potentially also picked up additional charges while they're in custody. So 12 cases have a next scheduled hearing date, and 3 are actually awaiting transfer to state prison. So those cases have effectively adjudicated and they're awaiting the transfer. There was particular interest in the assisted release court order data. And so again, this number may look different now, and we will do a review later in a future reentry network meeting. But as of December 31st, we had 50 individuals who were waiting court-ordered assisted release. And so most of them are going to come from our mental health and collaborative courts, as one might expect, and has been discussed in this body today, that these are people who are awaiting placement out in our community. For those who have a court order for an assisted release, this is their highest court charge, is categorized on this slide. The data is pulled from CJIC, which is the integrated database. People may have multiple charges on one case, but we're looking at the highest related charge because that's often what follows the sentence. And so these orders are predominantly issued from, again, our mental health and collaborative courts. So the category of pending competency determination is the most frequent charge category, and then that's followed by property crimes and then violence against a person. So that's a lot of data, and I did the best I could to be as quick and thorough. But I'm happy to take any questions that you might have. And again, a big thank you to our data team. This was quite a deep dive we asked them to go on.
Thank you. And I'm going to turn now to Laura, if you can get us started. And then I wanted everybody to see this in whole because I think seeing it in pieces is a little confusing. It's not on for some reason.
Is that better?
Yes,
Okay.
there we got you.
Good afternoon. My name is Laura McCabe. I'm a program manager, too, with the Office of the Sheriff. With me today is Dr. Patrick Marshall. He is our inmate rehab manager. And so I wanted to take the opportunity to go through some information on jail releases. I heard the conversation during the last meeting, and I thought it was interesting, and I thought we should really take a deeper dive into that release data. So today, during the last meeting, there was a lot of conversation about San Mateo County and Alameda County. So today we're going to take a comparative look at the Alameda County, San Mateo County, and Santa Clara County data, as well as examine more closely the Santa Clara County jail release data. We're going to take an opportunity to explain the policies and procedures related to jail releases, and as well as detail some information about how we prepare individuals for release. The data for this presentation was reported to the Board of State and Community Corrections, and as was mentioned earlier, it is a little different than the data previously presented. What we report to BSCC is data on those individuals who are released to the community, so it does not include individuals who are released to other agencies, to hospital, or to another facility. So the average daily population as you can see from this slide, this is a comparison, an average daily population between Santa Clara County, shown in blue, Alameda County, shown in red, and San Mateo County, shown in green. And as you can see, Santa Clara County has a much higher average daily population than the other counties. In taking a look at the total number of releases, Santa Clara County has reported in blue a slightly lower number of total releases than Alameda County, but as you can see, it's much larger than San Mateo County, shown in green. So since we're specifically the conversation that has been going around is talking about night releases, I wanted to take a look at and show some information on comparative night release data. Now, the information that's reported might not be what you colloquially would think, what we colloquially would think of as being night releases. It actually is night releases from 11 p.m. to just before 6 a.m. And the reason I use those numbers is because that's how we report it to BSCC. And so day releases are from 6 a.m. to just before 5 p.m. And then evening releases I considered 5 p.m. to just before 11 p.m. And that's how the data is reported. So as you can see here, percentage-wise, we have a large percentage of the Santa Clara County population, 44%, at 43% and 41% are all released during daylight hours, but that is a smaller percentage than Alameda County or San Mateo County. And for evening hours, we show 30% and 32% released during the evening hours. And then, as you can see, that's less than we find in Alameda County, although it's a greater percentage than in San Mateo County. It's these night releases, though, that has been such the topic of conversation. And as you can see from the bar graphs by percentage, Santa Clara County has a much larger percentage of our population, of our total releases released at night, and then Alameda County, although we're relatively similar except for September offshoot with San Mateo County. So if we look at our night releases, look specifically at the night releases, turn it back into numbers since we are referring to individuals who are released at night. This is the total number of individuals who were released at night in July, August, and September. Santa Clara County is shown in blue. Alameda County is shown in red, San Mateo in green. And as you can see, Santa Clara County has a much larger, by the numbers, number of releases that were done at night in those months. So I wanted to do a deeper dive and take a look at how what sort of prompted the release? How did those individuals, I guess, how were they released? There's a release code that's provided for each individual as they get released. And so I took a look at those release codes and I grouped them into 4 categories. Bail releases are anybody who bailed out. There are a number of codes that have to do with it, as a cash bail, property bail. But any bail release code fell into that category. Pretrial initiated release, I called it pretrial initiated. It might be pretrial assisted, but it's listed by release code as a pretrial release. Individuals who are cite and released, they came into the jail, they were cited, and then they were released. And then other releases might include some of those court releases, people who were released on their own recognizance by the court, people for whom there was no probable cause to hold them, and they were released. So I took a look at those numbers, and I found that bail release, the percentage of for the September number, going back, that September number was 526 individuals. So of those 526 individuals, 24% of them they were released through a bail release. 28% were released through some sort of pretrial initiated, pretrial assisted release. 19% were cited and released, and 29% were released for other reasons. So if we're going to take a look, we need to really take a look at each of these different categories and figure out which of these categories would be our main focus for our attention in the future in determining how to reduce the number of night releases. Now, we don't know, as we categorize these, we don't know that our categories are done the same as the other counties. We don't have information beyond what they have provided to be SCC, so we can't do a direct one-to-one comparison, but this is a deep dive into our numbers. So all of our releases are done. It's a paper. We still have a paper system, so of course it takes time. But our releases are processed as expeditiously as possible in accordance with applicable laws. California law does say that the jails can't hold individuals longer than permitted by law. When courts do indicate a daytime release, those releases are held and they are processed the next day. But any individual who's released from custody may remain in the lobby for as long as they need until they are ready to leave. That is also true in Alameda County as well. Individuals are able to remain in the lobby if they are released at night. We do our best to help prepare individuals for release. We work with a number of partners along the way. Our rehabilitation officers are really well connected with the individuals in custody. Even if you look at when they request information, inmate request forms, you can see that they know who their rehabilitation officer is, and they ask for them by name. And so the rehabilitation officers get to know the individuals through their periodic meetings, and they're really able to help identify their needs. They work with them to identify programming needs while they're in custody. They can refer them if an individual has a need. If a person at home has a need, then they are able to refer them to First Five or other resources. They also connect with individuals prior to their release, so they check regularly to see who is potentially going to be released in the future, and they meet with them within 2 weeks of their court date, so that they can work with the individual to connect them with services. They connect them with the Reentry Resource Center and other services that they may need. And I think, are there any questions?
So here's what I'm going to do. And I'm just doing a little bit of a time check because I know we're keeping folks late. What I'd like to do is I'd like to take public comment. I want to then open it up for questions. Then what I'm going to do is continue the item to the next meeting because it's actually a lot of information to digest. So I want to give people a chance to do that. And we'll put this first on the agenda. So we'll go to public comment first, and then Bob has questions.
I'm actually going to reserve till we come back.
Are you sure?
Yeah, absolutely.
I've already skipped you a bunch of times. Anyway, we'll go to public comment.
Great.
We'll go to public comment first.
Okay, so we have one submission. Paul Soto, you will have 2 minutes if you make your way up.
Paul Soto from the Horseshoe. I'd like some racial data on the felonies and all the felonies, the property felonies and the sex crimes, all these issues. Racial data would be important because in this era of equity, we have to assess that. Because how are we going to really institutionalize equity within the context of budget allocations with the counties and the cities if we don't have that data? And so the racial data, number one. Number two, bail releases and site releases, you don't have to worry. When they're in, they're immediately getting released, so they don't have to be factored into any kind of assessment when dealing with the medications. Pretrial release and other release do. So if you go to arraignment within 3 days, sometimes a portion of this pretrial and other releases are going to be released within 3 days. But there's also probably, if they're kept in custody, it's maybe a 10 to a 30-day threshold. So within 10 days to 30 days, these pretrial releases and other releases are going to be assessed by the court, and it's at that time when the medical issues can be assessed so that they are released with those medications. So if you cross-reference get the data, how long these pretrial releases and these other releases, how long do they stay in custody? How many are released at arraignment? How many are released within 10 days? And how many are released within 30 days? Once you get that data, then it'll give you a kind of a clear picture as to what it is you need to do in terms of a policy decision. Thank you.
Thank you. I'm gonna see if there are any questions from my colleagues. I'm gonna go to Christine.
I don't know if this is a question so much as it's a hypothetical for Dr. Marshall and for our new sheriff. Given that we have people who we know upon arrest are going to be here for years and years and years based on this data, over 3 years to up to, 10, 15, 12, some of them, knowing upon arrest, these people are going to be here for exorbitant amounts of time. If you had an unlimited budget and every dream that you could possibly imagine, how would you redesign programs for the people that are going to be in our custody for extended period of times waiting to go to trial? And I don't expect you to answer me right now. Think about it and maybe talk about it at the next meeting, but I'd love to know if you could do anything you wanted or that you thought was appropriate and in the best interests of those people in custody. What would you do, and what would you ask the county to put in place for them? Thanks.
Just to clarify, you said unlimited budget.
Unlimited budget. This is your dream program. What would it look like? Thank you.
That's actually a really interesting idea for our, did you want to respond, Dr. Marshall?
If I had an unlimited budget, I would streamline the whole system, intensive case management. We would have unlimited staff. Each individual would have their own case manager, where we can actually deliver and provide that wraparound support that the individuals need, and work with our community partners who would also have unlimited resources that we can actually connect and just kind of streamline the process, because that's the real key here. It's about the community coming together, working as one, and we do an amazing job of that now, as you've heard today in the great presentations that were given. And that's something we're always looking forward to, is connecting with our community partners and our other organizations so we can have success. But, that's if we had an unlimited budget, but we don't. So we have to actually, take a realistic approach and kind of streamline the services the best way we can so we can have success.
Yeah, I would actually just like to ditto what Dr. Marshall said, but from my perspective, one of the things I don't think requires unlimited budget, but does require substantial funding is to have the staffing in place today to where we can actually have that one-on-one caseload, or at least that liaison. So the moment somebody comes in to a correctional facility, they're connected with an individual all the way through that process. So we're ensuring they're getting the services they need. And I think that's an important piece, and we've had that conversation, and we'll continue to have that conversation.
All right, Molly, and then Casey.
Thank you. Thank you for the presentation. You had a slide with 4 bullet points, and with respect to that slide, we can't change California law. We don't want to hold people longer than they should be held. The lobby is a very uncomfortable place to hang out for 8 hours while you're waiting for it to get light outside. But what we can fix is the expeditious processing of releases, because we're still using physical paper and it takes too long. So I think we should really focus. Our night releases were way higher than other counties. I think we really need to fix that problem, and to me, it's low-hanging fruit. So I know Matt's had some conversations with the court, because the court and the people who are entering data into Odyssey need to be on board with us to do it together. But that's the place where we can fix the problem.
Yeah, I mean, one thing that we've talked about this quite a lot, and that's why I'm going to just continue the item, because I feel like this goes in the category of issues like making sure people have their medication, that you just kind of say, really, we can't figure this out, but we're going to figure it out. And so what I would just suggest is I know there's a good ideas forum, and I just want us to go from idea to action. So one thing that I'll just request, and then Casey, I'll turn it over to you, is that before the next meeting, I'd actually like an analysis of your recommendations of what we should be doing. And this was a good snapshot of what's happening, but what should we do to address that there are two, whatever the bottlenecks as each of you see them, because we always see bottlenecks in other people's processes. So let's go ahead and point those out to each other, because I'll want to hear an analysis of, based on what we've learned, what are the actions we should be taking. Casey?
Can I
Yeah,
add to
of
that
course.
just really quickly, because I would love, and the burning question I had so I can sleep tonight is, when you look at that data point and the 3 counties in comparison, Alameda is drastically lower in the amount of nighttime releases. So what are they doing? What processes do they have that we could maybe evaluate and maybe implement here? Because there's got to be something, because they're so consistently low and we're so consistently high. So.
Yeah, so 2 things. I think the point about, for those that might be interested in looking at the racial lens in terms of how the racial inequity and the charges that are filed, the District Attorney's Office recently released a report called their Race and Prosecution Report, which actually gives you a pie chart very clearly about all the cases that are filed and all the racial, demographic, gender, zip code where everybody lives. So you can really do a deep dive into that information. So that's just for everybody's understanding. But I think to the point that the sheriff just made about looking at Alameda, I think looking at the counties to see what they do, but I do think the technology, to Molly's point, seems to be a challenge for us. The paper filing, the paper record keeping back and forth, we're streamlining that with a database could be much more efficient. And I appreciate that you'd like analysis to come back, and we can certainly make recommendations. But I do think the stress test is really going to help to streamline that process for us and have very concrete evidence-based practices that have worked in other counties and are applicable in this one to reduce some of our perennial challenges as best we can.
First, other counties and states permit individuals who are being released, and there's really no plan for them, to make up to 3 phone calls at no cost to try and get a ride, reach their families. Do we do that?
Yes, so I do believe, Assistant Chair, there are a couple of things that I definitely think we provide them access to a phone. And the other thing is, if they don't have a ride, we have taxi vouchers upon release that any inmate can utilize. So they always have an ability to get a ride somewhere.
So you do let them make phone calls. All right. And the second, I would just suggest, Supervisor, that it might be helpful if the sheriff could provide us with a workflow processing similar to what we were looking at these slides as to what they need to go through, and Matt, of course, would be involved as well, to process a release, so we can better understand. I do not believe in nighttime releases. All of the releases I order are during the daytime, but I think that if we could better understand your challenges, I know there's a paperwork issue, but I think if we just understood it, we might be able to look at better practices that we might try to incorporate.
We can do.
All right, that's a really great idea. Did you want to add anything?
No, I was just agreeing that's something we can do. We
And you know,
work with,
one thing, let me just make an observation about the taxi vouchers and just say this, that in this room, we hear the optimal way programs work. But from talking to people who are in custody, I'm not always sure that people who are even discharging people know all of the resources. So I would just, I say that because in a number of instances, I can't, where we've let people out at odd hours, I can't believe they would just willingly walk somewhere if they knew they had a taxi voucher, and we get reports like that all the time. So I say that more, not to be disrespectful, but more just to say out loud to all of us that there's the thing we intend, there's the optimal outcome, and then there's testing what's really working on the ground. And that's an area where I want to make sure we're thinking in all of these areas, how are we doing that in a real way to know what works and doesn't. And I thought the point that Susan raised about, giving people resources, and I know that's not exactly what you were saying. What you were saying is we have a list of resources we can cull through. But having all of us, I think, maybe at one point in our lives been in a place where someone's handing you resources, it can be not just overwhelming, but super unhelpful. Like really unhelpful, because it leaves you to navigate a system that somebody else understands that you may or may not. And so anyway, I say that more because the reason I'm saying let's talk about recommendations is I really want to know, what do we need our agencies to do? We all know this problem. We've been talking about it for a long time. Now we've documented the problem. We can only wrestle the problem so long before the problem becomes us, right? And this is one I'd really like to fix. Matt, are you going to fix it for me? Go ahead. Yeah. You get the last word.
In support of what you're saying. And actually, I wanted to give a quick progress report on some of the things we're doing with the pretrial expansion funding. It's enabled us to start to meet with the court more frequently and look at what we can do.
Oh, good.
We're encouraging low tech. Casey was talking about technology. She's come over and spent time with us at admin booking. County council's come over. It's very antiquated. It needs support. And actually, here's a quick example of some low technology that could work and some things that we're starting to do. We have the CJIC team that's doing the data entry on the minute orders, and there's a delay. We get court orders, hundreds throughout the day, and some court orders supersede others, and some of them are difficult to read. If we took, for example, one of those data entry people and put them in the courtroom next to a scanning machine, and that person could quality assure that document in that moment, making sure we could really understand what Judge Manley is writing down, because it's not always that easy, no offense. And then we could actually start to process that release a lot earlier in the day. It's a simple no cost or low cost fix. It's the same employee that's already being paid, they're just placed in a different location.
Yeah, that's smart. And I will say that the courts have talked to us a lot about administrative strain, and in our courts in particular. Well, listen, I just want to encourage all of you to keep asking questions and keep pushing on each other, because that's really the way we're going to improve things. I really appreciated the conversations. I have to say, we've been doing this for a while. The reports are getting clearer and better as we've gone through. And so I just want to say thank you to everybody who produced something for this meeting. I appreciate all of you very, very much. Our next meeting will be April 19th, and we will start with this issue. So I will ask the clerk to repost these two last reports for discussion, and we'll take it from there. And I'll work perhaps with a few of the offices here, just so that we can start. I really do want to ask each of the offices that has a role here to play what their 2 or 3 big ideas are, or little inexpensive ideas. Good job, Matt. Matt already did his homework. All right, everybody, we are adjourned. Thank you.